because different services will struggle with things like workforce challenges in slightly different ways. But broadly for London, the access for urgent cases is gradually recovering, as is the access for routine cases post the pandemic. And for adults, again, those services are currently developing. So there's a variation in terms of the extent to which certain areas have what we would call a fully transformed model for adult services in place. Everyone is working towards it, but there is still definitely work to be done. So yeah, happy to take further questions or invite further reflections from Vic or Brian on that one.
My next question is to Dr. Agnes Ayton and also to Jesse Griffiths, right? But it is this: are GPs and other healthcare professionals sufficiently trained to recognize the signs of eating disorders and make appropriate referrals for specialist services?
Thank you very much for asking this question, and you're also highlighting an ongoing problem. We were working on a national survey of medical education a few years ago, looking at training of medical staff during undergraduate and postgraduate training, and highlighted that actually training was quite minimal. At undergraduate level, in 2018, it was less than 2 hours training in medical schools. And then at postgraduate level, there's a significant variation depending on what specialty and which deanery you're talking about. Since that survey, there has been some improvement. So BEAT and Health Education England has produced some e-learning materials co-produced with patients. Having said that, actually the assessment of knowledge during undergraduate and postgraduate training for doctors is still very limited, and obviously GPs are very busy. So I would say it's still an ongoing issue in terms of training of primary care staff. BEAT has produced actually patient guidance for patients to be able to approach their GPs the most effective way, because they felt that was a quicker way of improving recognition, but we have a long way to go.
Mm-hmm. Okay. And just you?
Yes, thank you. So you might be aware, and I think we will come on to this around the Parliamentary Health Service Ombudsman report, which indicated that strong recommendation was around medical training for around eating disorders. And I think as co-chair of the PHSO delivery group, it has been so difficult to cause change in that area, because there is, I guess, there's no mandate. It's not. It's optional training, what we've created, so we can't dictate who is trained and when. And I think that has been a frustration of the group, because we obviously recognise the need. We all know, we listen to, how common eating disorders are, and how across the pathway in acute settings where doctors will come across eating disorders but may not know them, they may be hidden in plain sight, they really need that training. But as of yet, we've not found a way of making that compulsory. Mm-hmm. So when I was the clinical lead on the project that wrote the training, the current training for foundation stage doctors, mm-hmm. and for medical students too, and I worked alongside BEAT to implement a campaign to lobby the medical schools to implement the training. And there was significant progress, but once again, it's optional from mm-hmm. the medical schools and the foundation programmes. And so it hasn't gone maybe as far as we'd like it to ensure that every single doctor is trained in eating disorders. At the minute, it's an average, from Agnes's survey, 2 hours for their whole medical training career, which we know is not enough.
No. I speak as a GP also, and that I recognise that. In fact, I was helped recently when I saw a patient who'd done a lot of the work herself, and given me a textbook consultation too, so I could make the appropriate referrals. So I recognise that, and also that is increasing GPC a huge variety of problems, and every specialist expects them to be a specialist, and they're not. But I recognise that this is a shortcut. But anyway, this is about hearing your evidence rather than mine. Emma, this is Emma Christie on the line. What is the NHS doing to improve the healthcare professional knowledge of eating disorders, and how can you ensure that appropriate referrals are being made consistently?
Yes, thank you. And I don't want to downplay any of the challenges raised by other colleagues, that they're very, very real, and I think echo the feedback of service colleagues working in London. I guess we've done a few things to try and support around the margins, I guess, in terms of producing resources to make, quick reference guides for primary care professionals to look at, to help identify and recognise some of the signs. There's also a number of signposting resources on Good Thinking, our digital wellbeing service for London. But I guess for me, it's really key that as we stand up the transformed models and pathways within the primary care networks in London, that those local primary care staff are able to be supported by the experts in those services and help improve the understanding in relation to eating disorders and that early identification, because it's really key that there's an early intervention opportunity as part of those transformed pathways, whether that's freed or kind of another similar model. So it's really important that those local areas are supported to, I guess, improve that awareness and support primary care colleagues in responding early to eating disorder signs.
Yeah, thank you. And Dr. Kumar and to Dr. Chapman, how has the introduction of waiting time standards for children and young people impacted access to services nationally and in London?
Yeah, I would like to keep my answer to London focus with giving you national perspective here. So London has got 8 NHS trusts who are providing children and adults eating disorder services. Out of those 8 NHS trusts, 6 provide services to both children and adults, and 1 provides only to adults and 1 provides only to children. There is a massive disparity between the access to care for children and adults, purely because in 2015 and 16, when NHS England thankfully invested £150 million across 70 services across the whole of England. Devolved nations were not involved in this process, by the way. As a result of which, they set up access and waiting time directive, which means that patients who are severely unwell or need urgent care must be seen within 1 week, and patients who are routine cases who are not severely unwell must be seen within 4 weeks. So London's figures, Children's Services figures for those access and waiting time directive in the last 2-3 years was quite poor, actually, and some of the colleagues in this panel will tell you that they were as low as 30% in some cases. It has improved in last 1 year because they have been able to invest some additional money. The dilemma or the difficulty has been within the NHS England, sometimes the money which was intended for children's eating disorder services have not reached the front line, and many of the colleagues will tell you that. And as a result, the services have not developed as they should have developed, because there is no accountability within the NHS system or tracking of the money, which means to be going to the front line or right people or right services. But that has helped massively nationally, and that is a feather in the cap of whole health system and professionals, and NHS in England. They have done a brilliant job to invest in frontline services in children's and young people's eating disorders, as a result of which the care has massively improved for children and young people. Even though the target meeting for those access and waiting time directive has been quite patchy nationally. Some services are amazingly good, some are lagging behind, and there was a staffing model which was published in 2015 and 16, but the implementation was again not uniform. And one of the lacking point has been the access to medical care. So as you would appreciate that not all GPs are trained to provide care to severely unwell children or adults who suffer from eating disorder. National Access and Waiting Time Directive focused on access to medical care, which can be, a difference between life and death for many of these children, has been lacking. Some services are very good. They went to form SLAs with local pediatric ward and pediatricians, as a result of which access to medical care has been good. But as I said, it is not consistent. But it is massive feather in the cap of NHS and good example of how investment in frontline services can bring massive changes and improve the care. But this has not happened in adult eating disorder services at all. So in London, uniformly, there is a massive waiting time for access to initial assessment. So on an average, there are 600 patients waiting at any time for assessment or initial assessment. And there are quite a number of patients, about 300 patients waiting for access to treatment, meaning that around 7,000 or approximately that number are waiting for access to care in London in adult eating disorder services, which is quite a huge number. And as a result of this waiting, what happens is that these patients become worse and worse. So if a patient who is suffering from eating disorder is chronically starved and not brought in under care and offered appropriate treatment, meaning that they will continue to deteriorate, their brain will continue to deteriorate, their heart, their kidneys, and all parts of the body. And if you try to treat these patients with offering them therapy, and we have colleagues who are expert in therapy in my team and many other teams within London, they will tell you that if your brain is starved and if you're offering them therapy, they're not going to engage as they would engage if they were properly nourished. And that's where the lack has been. And so at one hand, we have very good example of improved care in children's eating disorder, but there is a disparity on adult eating disorder services. In 2019, the NHS England and Department of Health published a blueprint for similar access and waiting time directive as it was in children's services, but it was not backed up with any funding or reasonable funding at all. So the time has come to invest more money in adult eating disorder services and be accountable to where the money is going and how it is being used and whether they are invested in evidence-based care or not. So that is the crucial element for improving services in London. That would be the message I would be giving to this honourable committee here.
Thank you. Dr. Chapman, did you have anything to add?
I would just agree with Ashish. I think that the Access and Waiting Time Directive has definitely improved access for children and young people. I think the pandemic has had a huge impact and some of the access and waiting time KPIs have not been met. We're now recovering overall in London in child and adolescent services. One of the issues is workforce, and there is a limited number of trained staff within the workforce in children and adolescents, and they tend to just move from one team to another. And so what results is that teams get left without enough staff and then cannot meet the needs of their patients. So training and thinking about a sustainable workforce is really important in eating disorders. Thank you.
Thank you. And Dr. Ayton and Dr. Sreenan, is there a need for waiting time standards for adults access eating disorders treatments, and could this be introduced at the London regional level?
Okay, so the Royal College of Psychiatrists has been promoting improved access and waiting times for all mental disorders, actually. But definitely we would be very keen to see similar approach across the age range. But it's not possible without a proportional funding. So the number of adults suffering from eating disorders is significantly larger than children and young people. And I think, although I probably shouldn't be speaking on behalf of NHS England, but the original idea was around the CAHMS investment, that by early intervention we can reduce the number of people who will have an eating disorder in adulthood. More recent research shows that the mean age of onset is 18. So that means that actually a significant proportion of patients have an onset after their adolescence. So that patient population cannot really be ignored, because then we end up in a two-tier system when a 17-and-a-half-year-old can wait a week for an urgent assessment, and an 18-and-a-half-year-old has 6 months to a year waiting time. And this issue was already highlighted in the PHSO report in 2017. He repeated his call again in 2013, kind of saying that there hasn't been sufficient progress. Obviously, we had the pandemic in the meantime, which focused maybe priorities elsewhere, but it's also showed a surge of eating disorders across the age range, so it's not just children and adolescents, but also adults.
Yeah, I'd just like to echo what you said, Agnes. I think there's the only thing that waiting list standards would do, in my opinion, without further funding, will just detract capacity from already stretched services. Some more capacity will go into number crunching and proving that we're doing something. Or else what happens in other services is books are fiddled in some way, so some kind of interventions are put in place of meaningful interventions or evidence-based interventions, and that can skew figure in favour, I think. So I think a lot of the resource will get wasted in terms of that, and it's already stretched resource, as you can hear from colleagues.
Okay, great. And the other thing is that we've heard that the autism is quite associated with eating disorders, but the waiting times for having your autism being assessed right is not met 76% of the time in London. Okay, so is this delaying the help of these people who have autism and have eating disorders getting the service? Yes, Doctor.
So very often, like anything else in the health system, these patients with eating disorder will present with significant level of comorbidities, and our age range for services go from 8 years to 18 years in children's eating disorder services, and many of these children are in developmental age, as you would appreciate, and so they present with attachment disorders, abuse, neglect, trauma, and neurodevelopmental condition, autism and ADHD and dyspraxia, and so on and so forth, and that affects the nature of illness with which they present. And RFID, which is a new diagnosis which came into picture in 2013, their numbers are increasing massively. The children's eating disorder services and adult eating disorder services are not able to cope with the massive number of these patients, or this category of patients which are coming to our services. Now, as you would appreciate, that children's eating disorder services are under National Access and Waiting Time Directive, as I mentioned earlier, that they must see these patients within certain time frame. Many times our GP colleagues, our school nurses, our frontline clinicians who could be A&E staff and so on and so forth, when they come to see these children, because there is a massive waiting time to assess children with autism or adult with autism or ADHD, but they want a quicker access to service, they end up referring these patients, sometimes wrongly, to children's eating disorder services. As a result, there is a massive backlog of these cases who are coming to our services, and there is no proper pathway or care system in place. And I do know that our NHS England colleagues are working very hard to streamline it, but there is a long way to go there. We need additional funding to help these children and adults with RFID cases or autism cases, definitely. And medical care to these patients is always a challenge, and deaths are happening because of lack of medical care. Let's not forget that. And many times these patients are also classified as wrongly so, chronic patients or treatment assistance cases, and then they are put in cold boxes, which is really heartbreaking as a clinician, I must say. And we need to keep away from that and focus on offering high level of care to these patients. Thank you.
Thank you. Jess?
So I don't know if you've heard of the PEACE pathway, but this is a specialist pathway for eating disorders, people with eating disorders who also have autism. And it's at the forefront of research into this area, based at the South London and Maudsley. So we actually have that pathway. And there's been new research conducted that I believe is coming out, in the next couple of years. But we are trying to replicate that model in other trusts in London to ensure that actually there are specialised pathways for people who are autistic.
Okay. Dr. Chapman?
I just want to add that the patients that sometimes become extremely ill and need admission to specialist eating disorder units, often with children and young people, have undiagnosed ASD. They have not had the assessment, maybe they're still on the waiting list. They need a specific treatment pathway. And as a result, quite often they get stuck in inpatient units without having the diagnosis. And very complex to treat. So I think there is a gap there, and I think it's very important that you mention the fact that the diagnosis and treatment of ASD is very, very important for these patients. I personally see the patients that maybe get detained under section, who spend maybe up to a year or more in inpatient units, often have that diagnosis but haven't been treated.
Thank you. I'm going to ask the other members of this committee now to ask the questions for their areas. And of course, before we had this formal session, we met some of the people who were the users of the services, and so we'll draw some of that experiences into our questioning here. So I'm going to ask you go over to Assembly Member Emma Bestride, who's joining us online. Over to you, Emma.
Thanks, Onka, and thanks to all the guests as well for joining us, and apologies for having to be virtual. I only have one working leg, unfortunately, at the moment, so it's quite difficult to get about. Before I go into my questions, I just wanted to follow up on that really interesting line that you're going through with Dr. Sahota about looking at the link between autism, and I couldn't help but go to thinking about the recent investigations and information coming out about the due to the backlogs and slow diagnosis people are experiencing within the NHS, this kind of new industry and sector really emerging and over-diagnosing and simplifying diagnoses of complicated mental health issues or OCD or other compulsive issues. And is there any concern that perhaps eating disorders could be caught up and lost as well, with people turning to that strain of diagnosis? And that's to anyone, sorry.
I would like to say that more work needs to be done. There is very limited resources within the eating disorder services or within CAHMS services, or definitely in adult eating disorder services, to explore more of the nature of these comorbidities. And unless more funding is provided, more training is provided, there are not enough trained staff or clinicians who would explore these signs and symptoms. We are already under lots of pressures with adult eating disorder patients or children's eating disorder patients. So we need to do more to find more evidence of this type of patients. Thank you.
I might just come in briefly on that as well. There's even when, so in some instances, a diagnosis is necessary in adult eating disorder services to support people with ARFID presentations. But across the capital, we did a bit of an audit last year, and there's at least there's a couple of trusts who can't accept referrals. They're not commissioned to accept referrals for ARFID within their adult eating disorder services. So it turns into a bit of a postcode lottery. Some areas accept them, other areas don't as well. So it really depends on where the person is living in terms of whether they might get support for this avoidant restrictive intake disorder. That's very highly correlated with autism.
I was just going to mention, in response to Emma's question really, and thoughts, that I was speaking to someone with lived experience last week who has autism and had so many hospital admissions, and because the inpatient ward wasn't appropriate for her, her needs and her accessibility needs and treatment adaptations, it really developed into a place where she lost trust in her treatment team, and it became traumatic to go to the very place where she needed that support and treatment. So I think there's a lot more we need to learn about autism and eating disorders. We know there's a huge crossover, and that there's a lot more we can do to support people better.
Thank you. I wanted to come on, Emma, I don't know if you want to come in on this question first, just to ask, has there been an increased demand for eating disorder services in London in the past 2 years? And if so, do eating disorder services in London have sufficient capacity to meet this demand? And I know that we've touched on this, but I suppose if there's anything else to add.
Yeah, I mean, I think I really welcome the comments from colleagues working in the services, but I think coming out of the COVID period, the most obviously impacted service line seemed to be children and young people's eating disorders, really, really significant increases in demand. And I think we could see that in the access standard data, which had been holding steady at 95% across both routine and urgent cases for a number of years, and suddenly, as colleagues reflected, it dropped. In some places, it was incredibly low. And then I think the kind of ongoing trend has been for just increased children and young people are sicker, so they need more support. So there was a kind of impact in the more routine referrals getting seen in time, because services felt they had to prioritise the most sick children and young people with the most serious presentations. That is gradually improving, and as I mentioned, additional investment has gone in different parts of London in response to what was a really big impact, but very conscious that from a mental health point of view more broadly, we're still working through the fallout from the pandemic in some ways, and some of these presentations might take more time to materialise. We haven't fully realised necessarily the impact of the children and young people who were out of school during the pandemic and so on. So I think there's definitely been a big impact on the children and young people's side. It has recovered. It's less obvious through the data for adults, but the data is less well developed, I would say. So I don't want to kind of detract from what colleagues have reflected in terms of the significant increase in demand across the adult pathway as well. But it was very, very noticeable for children and young people.
Thanks, Emma. And did anyone else on the panel want to come in on that?
Yes, I just wanted to sort of say that I think in CAHMS eating disorder services in London, towards the end of the pandemic, there was about 2.5 times increase in the number of referrals in some services across London in our service. And what we also noticed was that there was an increase, as Emma said, in very unwell young people who needed a lot of support, admissions to paediatric wards. Since the increase in funding, there has been an improvement in our and a natural drop in presentations. It's still above pre-pandemic level, so I think there's a natural increase in presentations for eating disorders that have been going on longer than the pandemic, and so that is what we're seeing now. Thank you.
Can I also come in? I think the data are really quite important. So we consulted our colleagues working in London, and the number of trusts are not accepting patients with mild and moderate eating disorders. So these patients are basically unknown and unrecorded in the current recording system. And what we have seen, I suppose probably the most robust data we have about severity of increase is the hospital admission data from NHS Digital. And there was an increase across the age range. So there were 21,000 admissions nationally for life-threatening eating disorder in the last year. And 7,000 children and young people were admitted. So I think we need to be really mindful of the quality of data available.
I would also like to bring in some important gaps in service provision in London, which is practiced and has been brought to our notice at Royal College of Psychiatrists. And as a Royal College of Psychiatrists, we are concerned with those deficient practices that in London pediatric wards, if a child is very unwell and needs to be admitted under Mental Health Act, which is you would try to do to save their lives, they are not allowed to be admitted under Mental Health Act, which is like deprivation of high quality of care to patients with those kind of severe end of the illness. which is a very poor practice, which I would want to highlight, which is happening in London, and that needs to be addressed as soon as possible. And the Honourable Committee asked whether there is a provision, there is a scope of doing something new or different in London, and definitely it can be done, and especially the patients who are waiting for 12 months to 18 months to access initial treatment or initial assessment, and then they're waiting for further treatment. So definitely through London Assembly, you can do anything you can do to lobby with the government and Department of Health to invest more money in adult eating disorder services, or invest directly to boost these services so that patients who are waiting for care can receive care in timely manner. That will be the great outcome.
I think that, so yeah, it's thrown into probably what my next question was going to be, and that is, what more can the GLA and the Mayor do? Perhaps, I think Onka's already touched, we don't have the power over the NHS, but we do. The Mayor certainly has convening powers to amplify messaging. Is there anything that you would like to see the Mayor doing with the support of the GLA?
I see your hand, so if you need to make a comment, just come in and make a comment.
There we go. Can you hear me? Thank you, Emma. If it's okay to just go back to your previous question, and then I'm happy to answer the next one as well. I think from talking to our colleagues across London, I think from what we know, actually the mild to moderate cases, certainly in the Maudsley, in our trust, we have no waiting list, or very short waiting list for those people at the minute. And actually people who are more severe and high risk, once again, actually we are managing well. It's actually the gaps in between. It's those people actually who around the moderate severity of eating disorders that are, I suppose, are waiting longer at the minute and have propensity possibly to get worse. And, you know, in terms of the general consensus, I think, is that eating disorders rates have increased across the pandemic, generally across the age range. And I think that's been widely researched and reported, really. So I just wanted to chip in there. I suppose in terms of answering, Emma, your next question around what can be done, from what I can see of the structures of the London Assembly, I would request that the Healthcare Board reviews the survey that you are currently undertaking and the evidence that you are collecting. I can see that the Mayor meets with the NHS London commissioners and people in that hierarchy, so I would request that actually there is a deep dive session within the Healthcare Board meeting that meets, I believe, 4 times a year. And I think within that, from understanding topics that are covered within that meeting, I believe there is the London Thrive network and organisation in terms of promoting mental health to Londoners. There was no mention of eating disorders on that website. I would really like to see signposting information on that website for Londoners to be able to access information about eating disorders, and also understanding, I think, you know, now the Healthy London Partnership, I think, has come to a close, and I'm not really sure what stage it's at. I'd really love to see what voluntary organisations, what can our community do in London to support people with eating disorders who need to, because actually it's our community and the community response that can make a huge difference to people's lives. Those conversations, I'm aware that you also do campaigns as well across London. I think there's lots we can do, but I would ask that this is put forward to the Healthcare Board, please.
Thank you.
It's hard to tell sometimes who wants to speak when you're online, so sorry for skipping over. But I can see as well that Emma online, I can see that one for sure. Emma online's got her hand up as well.
Sorry, just very briefly in response to Jess, and thanks, it's a really important point you flag about Thrive, and I will follow that up with colleagues not having any mention of eating disorders. We do have resources, as I said, on good thinking who work very closely with Thrive, but I think that's really important to pick up there too. Healthy London Partnership are now transforming partners in health and care, and they are taking forward some key priority programmes. One is very much focused on children and young people's access, and trying to kind of really roll out a 4-week weight access standard for CAHMS services more generally for London. And the other one's very much focused on advancing mental health inequalities and adult eating disorders. Children, young people's eating disorders would definitely fall under the banner of that work as well. So I just wanted to clarify both those points. Thank you.
I also wanted to highlight that there are quite a massive area of good practices which are available there. There is NICE guideline, there is MEAD guideline, which was published by the Royal College of Psychiatrists last year. There is massive scope of co-working with the Royal College of Psychiatrists and also London Assembly and the offices of Mayor of London and Department of Health and NHS England to implement those guidelines at the high level and also across the services. And uptake of MEAD guideline has been patchy across the services, whether that could be strengthened. And evidence-based therapies which are not easily accessible across all the boroughs of London, whether that could be strengthened as well, so that patients who are waiting for treatment, that they could be provided treatment in timely manner. The accountability of funding, because most of the funding which comes to frontline is not ring-fenced. So even though people can say that they have invested X amount of money, but that is not always invested in the eating disorder services. So some accountability through some joint working with the Royal College of Psychiatrists and Mayor of London's office and also Department of Health and NHS England would be helpful to keep all of us on track to improve care for children and adult eating disorder services. That will be quite important. Thank you.
Can I just jump in very briefly as well? For adult eating disorder services, I think one of the difficulties is that a lot of the funding gets pushed into kind of specialist services, but there's a whole range of eating disorders, and generally specialist services are supporting people on the moderate to severe end of the spectrum when it comes to physical health needs. And the kind of mild, moderate area goes neglected really, or they're rejected from eating disorder services. We talked already about how they're not captured in the data. But there's a whole workforce, so the IAPT, or Talking Therapies Initiative, their kind of primary care mental health services, they don't accept anybody with eating disorder diagnoses. Luckily in East London we developed a really good relationship with our 3 IAPT services, and now they see people with eating disorders. They've been trained and support. So there's a massive workforce that's going untapped, and there's some resistance to taking on people with eating disorders. And I think at the level we're talking about, the kind of mild, moderate level, there's much less risk compared to the kind of moderate to severe. The results coming out of our IAPT, or Talking Therapy services in primary care, are really, really excellent, not only in terms of recovery rates for eating disorders, but also in terms of the measures that their KPIs are based on, so the depression and anxiety measures too. So it seems to be kind of killing 2 birds with the one stone. So I'd really like to see that, kind of convening powers maybe that this Assembly has, to really think more deeply with the Talking Therapy services as to why they can't extend their provision for people with eating disorders. Obviously we can think about acceptance criteria and so forth, but the evidence coming out of East London anyways that they're being really, really taken care of well, and it's a massive success story here.
And I think following on from that, I would really love to hear from Emma at NHS London, really around how many mental health and wellbeing practitioners are being trained in London, because they are likely to be delivering guided self-help for binge eating disorder and bulimia nervosa. So yeah, I'd welcome a response from Emma to hear how that is being developed, because obviously those people, those mental health and wellbeing practitioners, would be able to support and treat mild to moderate cases.
So we're actually going to move on. The next question to Emma is about addressing the workforce challenges in relation to delivery of this eating disorder services in London. So maybe Emma, you could pick that up. And also, if you could pick up as well, how have services in London responded to the PHSO's findings of 2017 into eating disorder services within the NHS?
Hi, yes, thanks. So there's a few different elements to pick up there, so just making up. So I guess just to briefly touch on the Talking Therapies access, really keen to pick up, Brian, the kind of outputs from North East London in that space. There is work ongoing around that we're convening at a London level around just knitting together more effectively the Talking Therapies offer with community services, because the last thing we want to do is create cliff edges of support in some of these service lines, and we're aware that there will be people at a kind of milder, earlier stage in their experience of eating disorder that would definitely benefit from being able to access our talking therapy services. So that's definitely one to pick up and see what more we can do to support. In terms, I don't have the exact numbers, I'm afraid, of the mental health and wellbeing practitioners, but really happy to follow that up and pick up offline in terms of the opportunities with that workforce in primary care. We also have, in the children and young people side, significant rollout of mental health support teams in schools, and we've been doing work to provide them with resources around the early signs. And one of the things I was going to chip in was around the resources that we'd shared with mental health support teams, I guess, and the opportunities for early intervention, and really the kind of different resources that exist both at London specific level, like Good Thinking, but also the general NHS resources and signposting. And it's always welcome to have the Mayor and the GLA support in amplifying some of that messaging so that people do feel able to reach out and ask for support earlier in their experience and hopefully minimise an escalation or getting more unwell with an eating disorder, or getting that support earlier as well.
I think that's really key, and I have to say, from looking at the websites that are available to Londoners, there is a lot of signposting to charities, to eating disorder services, I think, and to the training even. So I looked through the new London Healthy Partnership, I can't remember what it's called, website today, and actually I thought it was actually quite confusing to navigate. So I would really encourage a much clearer strategy around signposting for Londoners. It needs to be clearer.
Okay, Emma, just coming back to you on your how services have responded to the PHSO's findings.
Can I come in here, and other people can help out? So I think
can I just quickly come back to Emma quickly on that one and circle back? Thanks.
Yeah, thanks. So I think what we've been trying to do is really provide that support offer and really, where possible, develop the services so that people can be identified and supported more early in the journey, but also so that for those people who need intensive support around their eating disorder, where possible, they can be supported close to home and with an intensive community support offer. So trying to kind of avoid the inpatient admission where possible. Just trying to double check. I guess, were there any specific elements that you wanted me to draw out?
Any changes really since 2017, which will have had, you know, or hopefully had a positive impact, or anything that's still kind of in train of addressing those challenges?
So I guess since 2017, we've significantly expanded investment into the community offer, and I suppose there's been development of guidance in response to some of the recommendations that's been rolled out. There is guidance in specialised inpatient service lines to try and respond to some of those challenges. I think that's all I could probably say. I would probably, if we could pass to Agnes to pick up on this one, because I think she'll be closer to some of the detail on that, that would be appreciated.
Okay, I'll pass over to Agnes. And Agnes, I just wondered if you could pick up then as well in your response, the follow-up meeting to that, to those findings. The Public Administration and Constitutional Affairs Committee agreed that GPs lacked knowledge around eating disorders, and I just wondered, not ONCA of course, but what schemes could be put in place to make sure more GPs were trained appropriately when it comes to eating disorders?
Is this question to Emma, or anyone can answer?
Emma said that was to Agnes. Sorry, okay, I was asking Agnes.
So just wanted to say here that many of the recommendations of the PHSO report, which came out in 2017, have not been implemented, unfortunately. And one of the major recommendations was that there should be improvement in the medical care or physical health care of eating disorder patients. There is massive gap in adult eating disorder world in terms of access to medical care. And there are many services, not only possibly in London, but outside, which are running without proper service level agreement and access to medical care for adult with eating disorders and children with eating disorders. So if these patients become severely unwell, people run around like headless chicken to offer them care. That is very poor practice in this modern day and age, I would say. That puts patients' life at risk and make them more unwell before you try to offer treatment to them. So that needs to improve. The uptake of, as I was saying earlier, meat guideline has to improve. It was called as marzipan guideline in the past, and we had a new version of it last year, which was published by the Royal College of Psychiatrists. So uptake of that has to improve, and all the recommendation which has come with meat guideline, that needs to be implemented quite seriously across the London services as well. That will mean that you need to have more doctors with a special interest in eating disorder to come to your services with medical care and medically trained. That has been lacking. The awareness and training for GP colleagues and GP nurse practitioners based in GP surgeries, the school nurses, they need to be informed and trained on meat guideline and medical care of patients, and they must be trained in picking up early warning signs of severity of illnesses in eating disorder world. That has been lacking. There has been a lack of coherent approach to training medical workforce and other workforce like nursing colleagues and also psychologists, psychotherapy, CBT, trained CBT therapists, and so on and so forth. So that needs to improve. And thankfully, colleagues have been doing national whole team training for adult teams and also children's team. That has been quite good, but we need to do more. Thanks to Professor Ulrike Smith and Professor Janet Trager's new model of care, a Freed model, which has been there for some time now, but access to that has been quite patchy across the London services. That can be improved because that looks after patients between 16 and 25. So if you implement it in with good funding for that, because lack of funding has caused lots of problems, as you would appreciate. And I do hear that there has been effort to improve funding, but it has not been consistent. So you might say centrally that I'm sending X amount of money for eating disorder. It never reaches there. There was a audit by the Beat to check out that how much of the national funding has actually been reaching the front line, and the outcome was quite poor actually. And that most of the funding was not ring-fenced, hence it never reached the front line and has never helped to improve the level of care for eating disorder patient as it should have done. And so good intention is there, and in some cases funding is also there, but it has not been ring-fenced, hence it has not reached the front line, and we need to improve that. And with this honourable committee and also London Assembly and the Office of the Mayor of London, I'm sure it can be achieved working with Emma and her office in London. We can make it better for patients and carers in London, and of course frontline clinicians as well. Thank you.
Thank you. I think obviously as sitting on the PHSO delivery group myself alongside Agnes, what has changed? I think we have created a lot of great stuff. We've created the meat guidance, we've created training. What we haven't done is had a strategy for implementation and accountability. So it's excellent GP training, medical training, training for whole team, but actually unless someone takes responsibility for implementing that in the boroughs of London, how do we know, that training is not going to be taken up? So I guess I would call upon, once again, the Healthcare Board, to present and say, well, actually, how can we hold our primary care colleagues, our trusts to account, and to encourage that eating disorder training and make it widely available, accessible, and give the clinicians the time they need to complete it. That is absolutely vital. We need accountability.
So, on that line, one of the things that I've been really quite worried about, that even when services have the funding, there isn't a transparency of patient outcomes. So we don't know what proportion of services are able to deliver evidence-based treatment, and we don't know if that evidence-based treatment is delivered, whether patients are benefiting from them. And that's something which, again, could be improved quite quickly. So, for example, child and adolescent eating disorder services collect a lot of outcome data, but it's not out in the public domain. And the Royal College of Psychiatrists has been kind of trying to work with NHS England and promoting outcome data for services. Because ultimately, you know, we are hearing stories, and I'm sure that you heard the stories from the patients when people have revolving door admissions, they have poor experience, and then we have individual stories rather than systematic data collection, and we need to have that transparency. We have done some work, as you probably know, changing the inpatient treatment model using the integrated cognitive behavior therapy model in Oxford, and when we looked at the comparative data elsewhere in the country, there was nothing else, which is, you know, not where you would want to be.
I think it's really important to indicate that within many of the eating disorder services within London, actually we are implementing an integrated care model. And I think, you know, Agnes is excellent. You know, an innovative ICBT pathway is really important, but actually that is being implemented across other trusts in London. We know that preventing admission is really important, because actually inpatient admissions don't necessarily ensure best outcomes, particularly obviously for people with anorexia nervosa. So I think we need collaboration and integration in the pathway, as Agnes has suggested. But within that, there are 3 obviously evidence-based treatments, particularly for anorexia, which are, one of them is CBT, one is Mantra, and one is SSCM. So it's really important that specialist services integrate their day patient programs when patients need more intensive support, you know, to inpatient programs if needed. But all of that care pathway needs very careful integration and collaboration to ensure that the patient's voice is heard, that they are encouraged towards a hopeful recovery, that it is possible. But I think one of the things hopefully I hope you're hearing from us is there are so many people that people with eating disorders come into contact with, so many clinicians, school, workplace. All of those people need to have an awareness of how to talk to someone with an eating disorder and how to spot them, and the treatment pathway too. So as I said, you know, I believe it's a community response, but I think it is this integrated collaborative approach that is vital.
I just agree with Agnes and Jess in terms of the outcome data and how services are maybe setting up excellent ways of treating patients, but there's no shared outcome, so no one can learn from each other's experience. For example, intensive outpatient services are being set up in children and adolescent mental health services as an alternative to inpatient treatment. So in our service, we have an intensive family treatment model, because with children, it's family treatment, which is the evidence-based treatment. And we've set up a system where we have managed to reduce referrals to inpatient units, where children, as I explained, have spend long periods of time away from their families, being treated in an environment where they are surrounded by other patients with eating disorders. And sometimes it's very hard for them to get better, and parents aren't given the skills to help them get better. And so we try and avoid admission by having these intensive services, and we've managed over the last 5 years to reduce admissions. But again, how do we share these outcomes so that other services can set up similar services in London?
Thanks. I've got a couple more questions, and so I mean, if people could try and be direct, but perhaps concise in the answers. Brian, if I could come to you first and ask if there's a lack of parity between children, adolescent, and adult services in London, and if so, is there any gaps there that should be addressed? Is there any differences that make sense?
Yeah, there's definitely a gap. There's a huge gap in funding. So the amount of funding that adult services get compared to children's services. There's some very simple things I think that would help with the levelling up process. One is the workforce calculator that was in the 2015, I think, CAHMS guidance for eating disorder services. For adults, there's no real model of like what does good look like, what does a good eating disorder service look like, how many psychiatrists, psychologists, nurses, etc. are there in national guidance. So I think something like that would be very helpful. But there's a huge disparity in terms of funding, and there's also huge gaps in terms of recruitment, and I think this is a massive area. Probably the same in CAHMS services, but in adult services, we're robbing Peter to pay Paul all over the place. People just, go from one service to another, but there's no kind of new blood coming into the system that will actually help us reach the targets and the huge demand that's placed in the system.
Just very quickly, I think that kind of goes back to the training. Ashish and I, we both ended up working in eating disorders because we had exposure during our higher training. And unless eating disorders are part of the curricula for the relevant specialties, including doctors, psychiatrists, psychologists, and nursing, mental health nurses, we won't have the next generation coming forward because they don't think it's relevant to them. So then people kind of end up working in eating disorders either accidentally or because of personal experience rather than having a kind of a systematic approach to the workforce issue.
Thanks. Agnes, if I could just stick for you quickly and just ask about the benefits of the Oxford ICBTE model and whether London trusts should adopt this.
Yes, thank you very much for asking that question. So if I just give a little bit of a background, I was sort of thinking that maybe the name is a bit overly complicated, so apologies for that. So the CBT is Enhanced Cognitive Behaviour Therapy, which was developed by Professor Fairburn in Oxford about 30-40 years ago. And it was a major milestone in the development of eating disorder treatment, and he actually received a major international award for his work, for his pioneering work. So it's an enhanced cognitive behavior therapy, which was developed with patients and specifically tailored to eating disorders. And the original development was for people who were not underweight, so not for anorexia nervosa, but bulimia, binge eating disorder. And then over the last 30 years, there has been work done, particularly in Italy, looking at how this model can be adopted for the extreme severe end of the spectrum, people who are actually in hospital sometimes with life-threatening eating disorders because we don't have good treatment for them. And basically, it's not very complicated. It's about integrating the physical, so nutritional rehabilitation and the psychological treatment and across the care pathway. So during admission, but also continuing with that treatment after admission in a gradual way. It is, in terms of implementation, can that be implemented elsewhere in the country? I think we have a lot of the ingredients already in inpatient services, but it's a different model. A lot of the current inpatient services, and I don't know whether people will shoot me down, but a lot of inpatient services kind of practices are kind of still stuck in the 1970s, 1980s, when the first specialist eating disorder units were developed, and they are very highly kind of structured and institutionalized. And this model is individualized, working with the patient's individual maintaining factors, looking at the here and now, and also looking at the future, how to help the patient to stay well and recover. And it took us a long time, so we started this process in 2016, and we published our data last year, looking at our outcomes, and we were able to compare it with elsewhere in the country because of the provider collaborative. And what we found, that people who received the integrated CBT model had 70% recovery rates as opposed to 5% in treatment as usual. And the readmission rates were 15% instead of about 50% in treatment as usual. And I suppose because of the pandemic, we had almost like a natural experiment, because during the pandemic we couldn't provide the whole care pathway, so we could only provide the inpatient bit. And what we found, that actually the integration of the psychological treatment across the care pathway was really key, because the outcomes, even though if we changed the inpatient treatment and reversed the malnutrition, the outcomes weren't as long-lasting without that integration. I don't know whether you have any questions or whether I've explained that clearly.
Thank you. No, that was really helpful. And I think all I do in finishing up on that is just maybe turn to Emma quickly and ask if the NHS has given any considering to adopting the Oxford model. NHS.
I'm not aware of any specific consideration of adopting that model in London, but definitely the focus is on the kind of integrated community offer and really strong integration across health and inpatient and community settings as well. And I do recognise a lot of Agnes's characterisation of some of the variation in the quality of the inpatient offer in some cases. So I think there's definitely work to do, and definitely something that we can pick up outside of here.
Yes, and just to echo that as well, like I said, you know, it's certainly within our trust there is this integrated pathway. Absolutely vital that we have that seamless transition between community treatment, more intensive treatment, inpatient treatment, alongside using those 3 psychological therapies according to the NICE guidance, which are SSEM, CBT is one of them, and mantra therapy.
Brilliant, thanks. And I'll pass back to you,
we need to press on. Have you finished, did you, Emma?
Yeah.
Yes.
I just said I'll pass back to you, Anka, yeah. And yeah, I did try to keep things concise, but...
Thank you. We now we have 2 big chunks to go through, okay? And also 5 o'clock, if we can finish by 5 o'clock. So if be mindful of that, please. Over to you, Kripesh.
Thank you, Chair. So I've got a set of questions which focus on health inequalities and access to services as well. So first of all, I would like to turn to Dr. Ayton and Dr. Kumar. So just understanding that particular groups of people find it harder to access treatments, and sometimes when they access them, their experiences may be negative. What impact do you think that has on patients? Maybe I'll turn to Dr. Ayton first. Yeah, if you could turn your microphone on, please.
Apologies. So thank you very much for this question. And I would say that, again, we don't have very good data. So the data we have is from NHS Digital 2019 Health Survey, which showed that there was a massive increase of eating disorders and people screening positive for eating disorders since the Adult Psychiatric Morbidity Survey in 2007. And the particular increase was among men of kind of 30s and 40s, where the rates quadrupled. And also there was a much higher rate of people with severe obesity. I can't recall whether ethnicity was recorded in that particular survey, but what we do know that in NHS specialist services, the patient population that we are seeing is about 90% white females. So we have a significant gap of accessing services in men, ethnic minorities, and other minority groups.
Okay, and feel free to add to it, but to Dr. Kumar as well. So do you have any information in terms of people's negative experiences of services?
So I think the negative experience happens because of lack of access in the first place. As you might know, that there are estimated 1.25 million patients in the population, or people with eating disorder in the population. We are reaching out to only a fraction of them, actually. As a result, there are quite a huge number of people with eating disorder in the community who are not accessing our services. Now, among the people who try to access our services, as you know, and I would not want to think, are we catering to males, are we catering to ethnic minorities, and are we building our team to cater to their needs? Is there capacity, is there training? I don't think so. We are lacking at this moment the training in the context of meeting the needs of core of eating disorder patients across the board nationally. I can tell you from Royal College of Psychiatrists point of view, and definitely in London. We need to build our teams to offer timely access to care, particularly adult eating disorder patients who are massively lacking, and it is causing high level of chronicity, high level of morbidity and mortality in this group of patients. So we need to be investing more in training, investing more in clinical services, and implementation of NICE guideline and MEET guideline, which has been severely lacking. And Royal College of Psychiatrists, and I'm sure voluntary organizations like BEAT and FIST have been working together over a number of years, but we need to make more progress through your honourable committee's help, and as well as London of Mayor's office's help in London to get more funding and resources to make it better.
Great. I just want to backtrack a bit around staffing, because that's one of the issues that was identified. And earlier today we heard from people with lived experiences about their experiences with services as well, and the knock-on impact of not having sort of regular staff, but also many staff that may be bank or agency staff that may not even have experience in working with people with eating disorders, and just what you felt the impact of that was for someone working in that service who may not really have encountered.
Yes, and as I was saying earlier, that there is a massive lack of concerted effort to train nurses, train doctors, train psychologists, therapists, CBT therapists, and different types of therapists in different types of therapy. Currently, we have research evidence to says that we treat only 50% of patients who are known to services or who have any kind of recovery.
I'm thinking or focusing more on people who have already entered the service of access services and are in the system as such, but still having negative experiences.
And that is purely because, and there are 2 or 3 reasons I could identify easily. One is that the people who are offering care, they're not trained enough to deal with a very complex end of the patients or severely unwell patients. And that itself causes massive level of staff turnover, because people who work in eating disorder services, they get burnt out very quickly because of high level of complexity and sometimes poor rate of recovery of patients. That is one factor itself. Number 1, there is not enough training happening, and if you're not trained enough, hence you can't deal with complexity and the volume of patients. And volume of patients is also a massive factor, because if I am a therapist or a nurse practitioner or a CBT therapist in a service, or I'm a psychiatrist in the service, and I have to deal with 200 patients, which is beyond my daily capacity to deal with them, naturally my intention and work pattern becomes that I ration it. So I go for severe end of the patients, which are more difficult to treat, as you would appreciate. So if we invested in early intervention and Freed model, which is a fantastic model to focus on early intervention can be done in a variety of other ways. And one of those would be to train our GP colleagues and train our nurse practitioners who are in school to focus on early identification of eating disorders and signpost them for right kind of therapies. Strengthening IAPT services in the community to pick up the early or lower end of the chronicity of patients who could be easily picked up and treated at earlier stage rather than waiting for them to deteriorate to BMI of 14 and 15, which many of the London services ration their services, and they would not accept patients if they are less than 15 BMI, for example. Because if you go for that patient, that puts extra burden on your existing staff. Let's not forget that. Because then you are dealing with very chronic end of the patient. It is no different to if I was a surgeon, I am getting gangrenous feet all the time rather than a small ulcer. If I focused on that, I can treat a small ulcer easily and get the patient up and running quickly rather than let them develop gangrene and then try to ampute their leg. That will be the nice way to put it forward to this committee. So we need to focus on early intervention and get them early, treat them early, and get them up and running and get them better sooner. So we need to invest more money on strengthening the services, staff training, which will reduce staff attrition and staff turnover, because there are good examples I've seen, because we get to hear about good teams across the country where if they've invested in staff training at high level, and that keeps the staff interested in their growth and development and upskilling of their knowledge and skills, and they remain in the team, they learn better, and they continue to serve in a better way, and patients get good deal of care actually. So that is quite important.
Good. And I know Dr. Chapman, you wanted to come in on this, but just before you do, also a question to you to wrap in your response. What do you feel the NHS is doing to ensure that it is improving access for all?
Thank you very much. I just wanted to make the point that the type of patients that struggle once they're in treatment, this is in children and adolescent services, quite often come from low income families. Treatment for children and adolescents is family treatment. So, as I think I've mentioned already, the family is very much part of the treatment model. And so quite often treatment is quite intensive. They may even have to come more than once a week. An average length of stay in treatment in a CAHMS service can be a year. And actually the cost of getting to outpatients can be a real struggle, especially giving up time at work. So that is something that happens quite often, I see across our service, the struggles of low-income families. So I think as well as the workforce sometimes not being as diverse as it should be to treat some of these populations. Thinking about what the NHS has done to support access, I've mentioned it already, but I think these intensive treatment pathways that are being developed in outpatients allows for outreach, in-reach into schools. It may be treatment at home. Some of those models are excellent, and they really try and support the treatment and prevent deterioration and admission to hospital. Thank you.
No, thank you. And I'm just turning to Emma online. So in January 2022, the Mayor stated that work was underway with London's integrated care systems, so the ICSs, to ensure equality of access to community eating disorder services. Do you have any details of this work and what has been the outcome so far?
So I suppose I would echo comments, I think, from Agnes that it's quite difficult to have visibility from the data that we can see in terms of the diversity of access. We have a lot of missing data in our caseload for adult eating disorders. I think that all of our systems in London are continuing to work within the community mental health framework and to develop that specialist pathway amongst adult eating disorder services. And part of the expectations around that is that we have good access to people from the diverse range of communities that we serve in London. And colleagues have picked up on the need to kind of have a workforce that reflects that diversity. So I think just continuing to work to try and deliver the objectives of the community mental health framework in relation to adult eating disorders is really the key way in which London is trying to respond to that statement from the mayor.
And will there be sort of any details or reports coming out as a result of that work, and when?
So there are no reports currently planned at a London level that I'm aware of. I know, Brian, I don't know if there's work that you were picking up while working on the Healthy London Partnership programme that responds to this, but there's not a report that I'm specifically aware of.
Yeah, there was some data collected in terms of how transformed services, adult services, were across the capital. And so some of the key points that came down from NHS in terms of recommendations were implementation of early intervention pathways, so like freed, elimination of BMI thresholds, clear arrangements about medical monitoring, etc. So we have information and data. It's probably November 22 was when it was all collected for a second time, just to see how much services have transformed. There's other things like self-referral. In some instances, I'd say 80% of services across London have early intervention pathways. I think only one service in East London has self-referral pathways. So I suppose there's a huge variation in terms of how transformed services are and how aligned they are to the national guidelines.
Okay.
I think just to reiterate what people have said about data, it's data that drives change in a sense, and within Freed we are asking all services to collect, we asked for quite a lot of data, and we ask services, I know it takes time and it's difficult to ask them to complete that data, but it gives us a picture of what's going on and who's not being served or who is not being offered treatment. So I think in terms of what we've all said, it's like without the data, it's really hard to present a case to the ICSs to say we need more funding. Does that make sense?
Yeah. I'm going to just turn to an issue that you mentioned, Dr. Sreenan, on elimination of BMI as a indicator on whether someone gets access to treatment or not. So you seem to allude that that is on the cards to be eliminated. What's the progress on that?
It's difficult to answer that question directly because a lot of services will say they have eliminated BMI thresholds, and yet diagnostic criteria for anorexia nervosa determines that you have to have a certain BMI. So there's a bit of a yes but going on with a lot of the services. So I think for anorexia it tends to be no, that BMI thresholds aren't because it's part of the diagnostic criteria. For other difficulties such as bulimia nervosa, binge eating disorder, or atypical presentations, BMI thresholds are definitely considered when people are either excluded from services or included from services. So I think the answer is yes, they're eliminated, but in practice it's a no.
Okay, that's not entirely clear. Is it ever appropriate, do you feel, for it to be used as a threshold?
Well, I think when you've got a limited staffing, I guess you need to think about how you're going to support residents. And what tends to happen, like people are saying, people don't have any services on the mild to moderate end of the spectrum. They become more and more unwell. And then there's a certain tipping point at certain BMIs where people jump the queue and will get seen exceptionally fast compared to their fellow residents. People who don't have, whose BMIs are within the normal range or the healthy range, or kind of 17 plus, they can sit on waiting lists for 16, 17 months easily, whereas people who kind of fall between the kind of under 14 or under 16 BMIs, they get expedited because of the immediate risk to health. But there's a kind of catch-22, I suppose, where the immediacy of the immediacy of impact on their physical health, that's what gets people expedited. But I think there's a growing, obviously we know about the kind of obesity pandemic, I suppose, or endemic.
I understand that. But are you aware that there may be people who are crying out for help, who cannot access help, who may be actually trying to impact what their weight and as a result BMI is, so that they can access services?
Yeah, definitely. So like we've got people, we talk to people with experience all the time in our service, and we've got one person dedicated to engage residents across East London. And yeah, there's numerous people have said that they've felt like they've had to get more and more unwell because they're not doing the eating disorder right. So this perverse incentive to become more and more unwell in order to get treatment. They also, very briefly, because this fellow colleague will lynch me if I don't mention it as well. But there's the physical impact of an eating disorder and the psychological impact of an eating disorder. They're two discrete things. So somebody can have a normal BMI but be psychologically extremely unwell, and vice versa as well. So I just wanted to get that in there as well. No,
that's helpful, because actually that was going to be my follow-up if you didn't mention it, because obviously someone may present with a BMI that doesn't get them access to services, but actually if it's clear that the psychological impact it's having on the individual means that they actually should be accessing services. I think that obviously needs to be a mechanism as to how that's taken into account. Just thinking about the waiting time as well, because for someone in this situation who, again, I feel is clearly having physical and mental impact on their lives, sadly many will turn to self-harm or other ways of maybe not looking after themselves. Are you aware of that impact, and what impact or support can be given for people? Ideally, we don't want waiting lists, but what support can be given when someone's has access to services, has been diagnosed as such, it's been verified that they should have access to services, but there's a recognition that there's going to be a wait before they're actually into services. So what support is given in the meantime?
Well, I think the reality is that not a lot is given when it comes to an eating disorder perspective. There's kind of handouts, there's psychoeducation, etc., given to people. But in terms of when people turn to other ways of regulating their emotions, so through self-harm or and other things like that, there are other services that people can access whilst waiting, like home treatment teams or crisis services across NHS trusts. But I think there are some initiatives in other areas of the country where there's podcasts being made for people who are on waiting lists, and some educational videos and kind of books that people can be supported to read through. But I think the staffing level is that chronic that people can't be supported, and there's a motivational stage as well where people are ready to change. But I think very often that's missed because people stay on waiting lists for months, if not years, and that kind of motivation to change can dwindle and then I suppose escape people, so people are caught in the trap for even longer too.
Okay, no, that's fair. So just to Emma online, so just turning into the work that's been conducted by NHS England and Improvement and the Healthy London Partnership, which is now the Transformation Partners in Health and Care. So lots of name changing and acronyms going on there. But what was the outcome of the work conducted by them to remove any barriers of access based on weight or BMI?
So I think this, again, to just sort of partially echo Brian's feedback, I think the kind of ambition of the programme with what was Healthy London Partnership was to support all of the 5 health geographies in London to establish the transformed models for community services, of which the adult eating disorder pathway was a key component. And as part of that, there were a number of different communities of practice established to really promote and share learning and good practice around the kind of guidance, which is very clear that the BMI threshold should never be the sole basis for a decision about access to services. But I think Brian has probably reflected a bit of that kind of reality in terms of the weights, where services do make difficult decisions when they're under pressure in terms of how to prioritise one case over another. And so, in fact, there will be scenarios where, to all intents and purposes, from a service user's experience, they do feel like they are being excluded. But the policy is clear, and I think that the aim of that piece of work was to ensure that that was, I guess, lived and breathed by services, that people shouldn't be excluded from services solely on the basis of BMI thresholds.
Thank you.
Thanks. I'm going to ask now to take us into the last lap, Assembly Member Caroline Russell.
Good afternoon, everyone, and thank you so much for all the information you've shared so far already. And we started off this afternoon with a group of people with lived experience, parents supporting young people and young adults, so people trying to access the adult services. So hearing what you've said has really kind of it's all resonated massively, because they have told us about the kind of devastating experiences they're having trying to access services for family members or for themselves. So this section is about community services and family support. I'm going to try and bring us in at 5 o'clock, so we'll all just have to be concise with answers if possible. So the first question is for Jess, and you've kind of touched on the sort of community response already, but do you think that more could be done nationally to harness the potential for voluntary organisations to provide that kind of lower intensity support to people with eating disorders or disordered eating, and also to the people that support those people, their families?
Yes, thank you. Yeah, absolutely. I think there are some excellent examples around the country where our third sector are providing a lot of the outreach, signposting, the low intensity care. So if you were to look at charities such as PEDS in Peterborough and First Steps in Derbyshire, they are actually providing free, some of them. They are commissioned to do some of that low intensity work. And I think over the past decade, I think we have de-skilled our primary care and some of the other resources that we have. And so the reality is that our specialist eating disorder services cannot do it all. They cannot do it all. And therefore, I think we need to skill up primary care again, skill up and build relationship and work in collaboration with our third sector partners, because they can do a lot of the work for us. It's so important to mention families. So when we think of someone who has an eating disorder, we are thinking about the structure around them. We are thinking about, you know, I, for instance, as a therapist working in outpatients, I'll see someone for an hour a week, but they come in the context of either a student home or a family where you know, they're there for a lot more of time providing support. We know that carers and family members are, you know, likely to develop their own mental health issue, 50% of them, from supporting someone with an eating disorder. So we need to look after them. We need to skill them up. We need to provide them support. And we all need to work together. I think none of us can do this on our own. So a partnership, supporting our carers, supporting those people who are in treatment themselves, understanding that we're better together. There is lots of resource that we can provide for our family members in the community, such as in schools. You could do a carers workshop, understanding eating disorders. There's lots of things you could do in community groups and youth clubs to raise awareness and skill up our community.
That's very much what we were hearing in the earlier session today, that kind of sense of people being desperate to find information, to find support. They described the lack of training within the medical systems that they were accessing, but also the lack of information within the community. So they were talking about, you know, people saying, well, just give her a banana, you know, make her eat something, and how incredibly unhelpful that is and undermining to someone who is trying to support someone with an eating disorder.
So isolating, you know, people, I know those who are carers of you know, people with eating disorders just say that they're so hard to find someone who understands. You know, they're so isolated, so stigmatised as an illness.
So is there, do you think, because I mean, one of the things that the Mayor of London has is sort of convening and communicating powers. Do you think that there are things that could be helpful that the Mayor might be able to do around that piece about raising awareness about eating disorders and how to speak about them, how to support people?
100%. There's so much we could do. There is, I know that he's done campaigns recently with Zero Suicide and how that has been disseminated across London. There is a load we could do if we were given the opportunity, because, like I said, eating disorders impact so many areas of life. Social eating, calories on menus, going to the supermarket. There are so many places where you could put those messages out. So yeah, absolutely.
Thank you. I'm going to keep moving through my questions. So the next question is for Emma, Brian and Vic, so you may want to kind of just split it up between you, but how does the NHS in London work with voluntary organisations to provide that lower intensity support to both to people with eating disorders and also the people who support them, their families? Who wants to go first? Or does just one of you want to? Emma.
I'm happy to kick us off and then pass to Brian and Vic. Yeah, I guess we've seen some really good examples, particularly in some of our pathways for children and young people, where our provider collaboratives, who are provider-led collaboratives that we, I suppose, delegate the commissioning of some of the specialist inpatient pathways to, and they improve those pathways and reinvest in community services. There's been good examples of buying in voluntary sector support around waiting well and support for parents and carers in relation to eating disorders. There's also lots of resources, as I've mentioned earlier, although really keen to pick up on Jess's feedback about accessibility and navigation around those, online available for parents and carers. And I think more broadly, the community framework is really about developing a kind of integrated support offer that draws on primary care, secondary care and community-based close to home settings and voluntary sector partners to respond to a range of different needs that someone might present with, whether that be an eating disorder or another serious mental health condition. So I think there are examples and lots of pockets of good practice across London, but it's probably not consistently in place everywhere.
Thank you.
I might just briefly jump in to say that I think involving third sector organisations is fantastic, and there's massive resource there and massive skills and intelligence there. But I think it needs to be an adjunct to NHS provided nice evidence-based care, I guess. I think if you're getting the third sector, who often have very precarious contracts, precarious funding situations, etc., to be delivering treatment for eating disorders, I think we're going down the wrong path here. So I think it does need to be an adjunct, and I think it can support the system. And there is some elements in adult eating disorder service across London that have good practice. But I think we can't rely, and we shouldn't rely on charity sector organisations to provide that.
Yeah, so it's kind of fix the issues within the services in terms of workforce and funding and provision,
primary care and
but make sure that there is that more community awareness, so that within communities people don't say the unhelpful things to a parent who's struggling. Yeah. Vic, did you want to add anything?
Yes, I just want to say, when you asked that question, I was thinking within the area that I work that we don't use voluntary sector very often. We do use BEAT to support families and ARFID groups. But I think the risk that we're dealing with, quite often it's very difficult to sort of delegate out. Yeah. But I do think voluntary sector going into schools, I have patients who have been given a letter about their BMI, because they've sort of gone over the range, and parents have talked about it. That sort of thing, help supporting schools understanding how to manage their whole sort of health and health policy with eating and nutrition and things like that. I think that would be really good.
Mm-hmm. And then, does anyone have anything extra that they want to say about the role that carers and family play in supporting someone with an eating disorder? And do we think that that those carers and families both are being, is their support being harnessed, but also are those families getting the support that they need, do you think, in the system? Ashish, did you want to come in?
Yes, so quite a lot of research has happened, and we are working on a new research called Triangle, basically, which involves parents, young people, and clinicians. So Triangle is not an acronym. It is three angles of Triangle are parents, carers, patient, and the clinician, which is a innovative way of helping people with eating disorders by involving this vital resource of parents and carers. And one part of that is to train them. So what is eating disorder? What are the difficulties you are likely to see in your young people or adults even? Because Triangle model looks after children and also looks after adults with eating disorders. And by doing so, because as you would appreciate, most of these patients, either they are young people or they are adults, they try to not to come out with their disorder because the nature of illness is such that it thrives on hiding it and not seeking help. And we as system, as clinician, whether we are in voluntary sector or we are in formal sector as in NHS or private sector, we need to focus on that. So who is around the patient, who could listen to them, their inner feeling, who could take them to variety of appointments or help? Because this illness thrives on secrecy, this illness thrives on hiding. So parents know their children or their relative. When I say parents and carers, there could be a sibling, there could be a relative who is close to the patient. So that is quite important part which has not been tapped very well, that how to train and educate the parents and carers about eating disorder and engage them in the treatment which we offer, because they are very vital resource of the whole picture.
Yeah.
And Triangle model tries to address that, and variety of other models such as family therapy model, and there are different types of family therapy model which tries to encourage that. There are many services who have informal arrangement with parents and care. They run parent and carer group, for example. FIST is there, which is a voluntary sector organization which tries to train parents and carers. And they run formal programs as well to train parents and carers to support their young people or adults with eating disorders. So that needs to be, engaged, and that needs to be improved quite a lot in our services. Thank you.
Is there anyone else who wants to add anything on the parents and carers?
I would like to add an important issue that hasn't really come up in the discussion is about kind of primary prevention and trying to reduce stigma and raise awareness, and that's something that maybe the mayor can help with. One of the issues that most clinicians are aware of, particularly if you work with children and young people, that the current kind of school-based kind of weighing children and sending letters about their weight or BMI may be inadvertently counterproductive. And coordinating the obesity prevention and eating disorder prevention policies would be really helpful, because it's the two sides of the same coin. And also, in fact, the health survey showed that the higher rate of eating disorders are in the obese population, and these patients are actually not known to secondary services. So there is a really important opportunity to raise awareness, reduce stigma, and that would help actually access to services by the currently kind of neglected groups, such as ethnic minorities or men, because there is a general principle in medicine: the earlier the intervention, the most cost-effective and most effective the intervention is. So eating disorders are no exception to that.
Thank you. And actually, you kind of answered the final question, which is a question for everyone, which is, what action would you like to see the Mayor of London take to improve access to and outcomes from eating disorder services in London? So shall I go to Emma first online, and then I'll come round to all of you. And Agnes, you've given us one really good idea, so don't feel you have to come up with another one, but you can if you have one. Emma.
Thank you. I would just endorse what other colleagues have said in terms of using his platform and influence to raise awareness, but also to add his, I guess, political power behind the kind of need for additional resources as we move out of the long-term plan. So I think what we would say is it's job begun, not job done. And there's clearly lots of need out there, and there are diverse communities that we're not serving as best we could. And I think conversations around that and any influence he can bring to bear on government would be really valuable.
Thank you. Jess.
Yes, thank you. I mean, I've mentioned a few options around this. I guess, echoing what Emma said, I think, yes, raising awareness in London is something I believe the Mayor could really be influential and actually implement. It's actually achievable. Influencing government, absolutely. Since 2017, we've not really had many people in government that have been interested in eating disorders, so absolutely that would be vital. Once again, I'd implore the Health Board Committee to do a deep dive into eating disorders and the outcomes of the survey and the discussions we've had in these 2 sessions to be presented as well within that as an area of importance within London, and community support. But I think also adaptive community support to those from different cultural backgrounds. I think it needs to be very well thought through in terms of how we target that community outreach.
Thank you. Ashish.
We already have very good example of success in eating disorder world, which is by when we had ring-fenced money coming to children's eating disorder services. It changed the landscape of care, a high level of care which was available, made to children and young people and their families. So why don't we learn from that and implement that in adult eating disorder services? Why we are trying to reinvent the wheel time after time? So we can learn from that, and NHS England Department of Health should be proud of those achievements. We just need to cross the barrier, go to adult eating disorder services. What we have learned from there, just implement it there. 2009, people do not know this. Many people at least don't know this, that there is already a NHS England and Department of Health blueprint and guideline on setting up adult eating disorder services, which was published in 2019. Unfortunate part was that it was not backed up by enough funding. So I think Mayor of London can help us to look at that and campaign for that it is backed up by enough funding. Accountability in the NHS system is quite important. Many times money is sent from central NHS, it never reaches the front line. This has happened in NHS London as well. So Mayor of London and his office can take care of that as well. That will be really helpful.
Well,
thank you.
They can advocate. They don't have money to hand out, but yes.
No, I know that. So,
yeah. But absolutely adding a voice to underpin those calls. Yes.
Thank
Agnes,
you.
did you want to add anything to what you said before?
I was sort of wondering whether the Mayor would be able to engage more with universities. So there are kind of multiple opportunities. So one is about the undergraduate training that I mentioned, and in the PHSA group, we were told that it's down to individual universities. So there isn't a central body which can instruct the universities to improve eating disorder training. So if the Mayor could advocate for improving eating disorder training for the relevant professionals and educational staff, that would be helpful. But then also the other important aspect is encouraging further research. So London has been world leading in eating disorder research, but we need the next generation of researcher and clinical academics, and that would bring benefit to patients. Hopefully, would also develop new treatments. So I suppose that's something else that he might be able to help with.
Thank you, Brian.
Yeah, I'm going to mention primary care again and bringing primary care mental health services around the table, maybe with convening powers that the office might have. I think that'd be a great result for adult eating disorder services and have instant impact. I'd echo Agnes as well about the research. We have, in East London, huge populations of minoritized communities, and yet they're not presenting to our eating disorder services. And there's no kind of nobody has the answers to that. So I think, if there's any funding to commission research or to really prioritise that research, especially in kind of Southeast Asian communities where presentation is really, really at the last minute, and they're kind of being at an inpatient level, as opposed to kind of accessing any of the treatment that we have prior to that as well. We don't know the answers. We've asked so many people, but yeah, I think research on that would be brilliant.
Thank you. And Vic?
Yeah, very briefly, I won't add on to what everyone else has said, but I suppose the message around healthy eating and how counterintuitive that it can be for children in schools, and how that is about thinking about preventing eating disorders developing. If you've got a sort of common language where you're not stigmatizing people that are overweight or using that sort of language, I know that you've already addressed the fact about the menus in restaurants having calories on them. I think that's not a positive thing. And just finally, concessions in transport. I know the Mayor has something to do with London Transport. Is there possibility that families who are travelling back and forth can have some sort of concession in terms of travel and transport?
That's an interesting idea. I don't know, but we can take it away. But that's a really because when you made the point earlier about the impact on low-income families, not only there's the cost of the travel, but also the cost of the time and time off work. So that's a really interesting idea.
Okay.
We'll yeah,
Thank you.
see where it goes. I'm going to hand back to the chair now.
Great. Thank you. Thank you for getting us nearly on time. Look, first of all, let me thank all the guests here for your contributions today. And can I ask the committee to note the report in today's discussion? Can we also delegate authority to me as chair in consultation with the party group lead members to agree any output from the discussion?
Agreed.
Can we note the committee's work programme and the additional activity undertaken since our last meeting? The informal briefing sessions with the Regional Director of Public Health, NHS England, regarding HIV transmissions on July the 10th, 2023.
Agreed.
And with the London School of Hygiene and Tropical Medicine regarding the Transport for London Young Food Advertising ban on 25th of July 2023. The date of the next meeting of the committee is on the 29th of November 2023 at 10 a.m. here in the chamber at City Hall.
Okay.
I have no urgent business. I therefore declare this meeting closed.